in here. That way it's a good way to know which patient you're dealing with.
Okay, go ahead.
So Kitty's finished with his treatment. I'm going to put him back into his cage. He's been very good. I'm going to pick him up, again being careful that I'm aware of whatever he's here for, any kind of wounds or such. I'm going to double check the cage card that I am going into the right cage and gently place him back up. Slide him in there. We have these double locks, so I'm going to double lock the cages just so to make sure that I've got them closed. And he's put up. Get this cat out of the cage for a nail trim. Actually, this is Kitty. His name is Kitty. I want to look at his cage card to make sure that I am getting the right patient and look at any kind of special notes that are on there. And this one does say caution for restraint, and venipuncture seems to not be uncomfortable with that. So I do have a towel standing by in case I need it. So I'll just take my time and go in slowly. Also want to be aware of whatever he's here for. If he might have a catheter, a urinary catheter, or if he's a surgery patient, so that I can be aware of how I need to pick him up and have control of him, and then take him over to our treatment table. And that's it. I'm going to demonstrate how to restrain for a blood draw. John's getting a PCD, so I want to have control of my patient and be able to listen to the technician. That's fine, you can stop there. Okay. Alright, so I'm going to do a physical exam on Layla. She's a patient that I mentioned earlier that is getting an FHO. So I'm going to start with an exam, and you start with her face and know any kind of symmetry or asymmetry and everything. There's no obvious swelling. Ears look nice and clean, like the daughter of a technician. Eyes are nice and white. No discharge. Teeth could be better. I'd give her some calculus in the back, but minimal gingivitis, so I would say that she's a grade 1 periodontal disease. Feel her lymph nodes. Good girl. Okay, stand up. Just going to palpate over her body, feel for any masses. Not feel anything. Give her body condition score maybe a 3 out of 5. Feel her pulses. Pulses are symmetric. I'm going to palpate her abdomen. See if she's a little painful there. I think I just surprised her since she's not responding again. She could benefit from a nail trim. She is resistant, but this is her bad leg. This one. A little more flexibility in that one. And up. Good girl. And up. Good girl. Very good. Alright, I'm going to get her vitals now. Listen to her heart. I'm going to count the beats in 15 seconds. Listen to her heart. Her lungs. That's a good girl. Sit down. Nice and clear. She's panting. Alright, so I'll get her temperature now. What? Start right there. Stay right here, girl. I know. Good girl. Stay right there. I know. She stopped panting now, so I can count her respirations. One more second. Hold on. Temperature is 101.2. And mucous membranes, pink. Capillary refill time, less than 1. So, coat is nice and full, no obvious wounds or hair loss. Any kind of, I don't see any fleas on her. Let me double check though. She better not. She doesn't so far. So I think that the abnormalities that are known are the hips, which we're aware of, and her teeth, which I'm ashamed of. And she probably didn't benefit from having her anal glands expressed. But otherwise, her blood work was normal. Everything was within normal limits, as was her vitals. So running her on LRS during her surgical procedure would be appropriate, and with a fentanyl drip, she should be a great patient, great candidate for surgery. That's it. A follow-up on that video that I just completed, giving Layla that exam, provided that we did do blood work, and all of her blood work was within normal limits, and she is 7 years old, so we did a PT and PTT, and we did a CBC and a chemistry, and everything was always within normal limits, thank goodness. And we also did some chest rads because she is 7 years old, therefore considered a senior, and hurts my heart. And her physical exam was pretty unremarkable, and she is a healthy 7-year-old golden retriever who's up to date on her vaccines. She's on Trifexis, she's heartworm negative, she's on Dasequin daily and an omega supplement daily, and she's also on a joint supplement, JM from Purina. So I would give her an ASA grading of 1. She is, with the exception of her age, she's a healthy animal. So again, I believe that she is a great candidate for a surgical procedure. You can turn it off now.
Action.
I'm going to demonstrate how to draw blood from a jugular vein on ether for CBC. Alright, so Leslie's holding off, and I am going to hold off above the thoracic inlet and palpate the jugular vein. And I did spray it with a little bit of alcohol. Want your bevel to be up. Leslie will hold off, and that's it. You can turn it off. No. Good kitty, good kitty, good kitty. Good kitty.
Hold on, Choo-Choo.
Almost. There it goes. Oh, yeah.
2 mils.
2 mils, please.
Mr. I can't get all my guys sent home.
Yay!
No.
Penelope?
That's true. So, Mr. Man here has biopsies. He can eat by 4 a.m. Stomach, duodenum, jejunum. Okay. I left everything else alone. Okay.
Hope you're getting all the snot sounds in there too.
Pan out so you can see your face.
Oh yeah, make sure.
Dread is
It should have been.
Oh my gosh.
Catch it, catch it. Come on, please, dog. Okay, that's what you can.
And then, so this.
I'm going to do 2.6 and 2.7, which is talking about the minimum databases or any additional database, databases or tests that might be needed. So minimum databases would be your signalment on the PET. That is just the baseline. We have to know that on any patient that's coming in for any kind of procedure whatsoever. We need to know their age, their sexual reproduction, their reproductive status. That has a lot to do with a lot of the problems that we might be seeing, for instance, a pyometra. We also need to know the TPR on the patient. The TPR is going to tell us right away what may or may not be out of range. If the patient's having difficulty breathing or might be hypothermic, we'll want to consider their body condition score. That's really important because that has a lot to do with how they're going to handle their drugs. I can't think of the word. But if they are going to be anesthetized, then that's going to conflict, or that's going to vary greatly on how they are managed by us under anesthesia. They might have a harder time managing their temperature. They could wake up slower. I'm assuming that they're overweight, but if they're underweight, that would be a problem as well. We're going to want to check their hydration status. That's important. Anything that is correctable, we'll want to try to correct before admitting to surgery. If baseline blood work would be a CBC and a chemistry. A heartworm status is definitely needed. If we don't have that, then we're definitely going to want to do that test. And for surgery, we'll want to do a PT-PTT, which is going to check for our clotting factors. And we're also going to want to check a blood glucose. Any other baseline? I think I pretty much covered it. And so now if we're any kind of abnormalities like I just touched on that can be corrected, we're going to want to correct or test further on. If during the TPR we auscult a heart murmur or any kind of stridor, then we're going to want to bring that to the doctor's attention to see if that's something that needs to be further worked up with chest radiographs or an EKG. Any kind of masses that might be palpated in the abdomen when we're doing our physical exam, that may warrant some abdominal imaging with radiographs or ultrasound. And CT is always an option. That's a department that I work in, and CT is one that unfortunately isn't utilized as much as it should be. It's just because it's expensive, but it's very useful. So anywhere that there's any kind of pain that is palpated or noticed during the physical exam, then that's something that we'll want to address. We'll also do, just anything. If we notice that there's weeping in the eyes or an ear infection, or maybe just that the patient really needs a nail trim while it's under anesthesia because it's been something that's been neglected. So while the patient's anesthetized, it's an ideal time to address everything that you possibly can within reason that, of course, the owner consents to. So now, supposing that our patient is a geriatric patient that's come in, then just right off the bat, that's going to add a couple of more things that we're going to do as a baseline. It's still going to be a baseline, but it adds a little bit more. They're going to get chest films no matter what before they go to surgery. We're going to check for the size and the shape of the heart, and we're also going to be looking for metastasis in the lung, or even just any kind of obvious lung disease that's going to put them at a greater risk anesthetically. We may or may not require a T4, but sometimes that's something that I don't think that that's really something necessary for surgery, but it is a baseline test that's added on for senior patients, is that T4. EKG, I think I may have mentioned that it's not something that we per se require for senior patients unless a heart murmur or irregularity is noted on physical exam or x-ray. Echocardiogram, that's another thing, another type of imaging that we may or may not do before surgery. Definitely will strongly recommended if the irregularity is noted, but just baseline, it's not based on age. So let me check my note. Physical databases, lab work, radiographs. I think that pretty much covers everything. So injuries, that's one thing I didn't touch on. Any kind of injury that's coming in on physical exam that's real obvious, a broken bone or a bleeding wound, then it's not going to go to surgery right away, but we want to try and make the patient comfortable, so we want to notice it, clean any kind of wound that needs to be cleaned, wrapped any kind of wound that needs to be wrapped, and make sure that we're utilizing e-collars and whatever kind of restraint device that we need to use to keep that patient from doing more harm to himself, obviously. And I think that's it. Thanks. Anesthesia machine. I'm going to demonstrate how to perform a leak test and also just explain the pieces of the anesthesia machine. Once we have the anesthesia machine plugged into the oxygen from the source, and we have the scavenging as well here. So the first step, it goes through our flow meter where we turn the oxygen on. We can also flush oxygen through the circuit at a more rapid rate if we need to do that. The oxygen will travel through to the vaporizer where you can turn it on, and there's a gauge here that explains in a percent how much isoflurane is actually going to be going to our patient. This actually houses isoflurane, and we'll fill it up right here. I'm going to turn the oxygen off for now. We fill it up here, and there's two gauges here where we can check to see if it's full or not. This one should be full, and this one has the full line that's going to be halfway. So it's going through the flow meter to the vaporizer and coming up to our patient. If our patient is breathing it and it's intubated, then we'll see the bag moving, we'll see a flutter here, we'll see some fog coming from the tube that shows that we are actually intubated. If not, if we run into any trouble, then you can put a mask on and give that to the patient, deliver it that way. When the patient exhales, then the gas will travel back through the tube into the Sodasorb, our CO2 absorber here, and it'll absorb the CO2 and scavenge it out through the machine to a scavenger, and then the clean air, what's left over, any oxygen or anesthesia, will just continue going through the rebreathing circuit. So I'll demonstrate how to do a leak test here. We want to plug up one side. You can use your thumb. Some people use another bag. Turn your oxygen on. Close your pop-off valve, which I didn't explain a minute ago either. Pop-off valve, there's two. You can screw it closed, and that closes the circuit. So you'll see that the bag is filling up, which is good. But if this was closed and we were connected to the patient, then that would be its lungs expanding, which is bad. So keep this open all the time unless we're trying to manually bag our patient. If we notice that he's not breathing or having a difficult time getting to our level of anesthesia, you can close this and then manually breathe for your patient. Watching your pressure valve, you don't want it to go over 20 if it's a smaller patient or 40 if it's a larger patient. Again, making sure that your pop-off valve is open and everything is good. So now I'm going to show non-rebreathing circuit, which takes this off, and we actually bypass the CO2 absorber altogether. So the oxygen goes through the flow meter, picks up at the vaporizer, and goes straight to the patient. And then the exhaled gas goes straight through to the scavenging system here. There's no pop-off valve, there's no meters, so it's very important that when we're monitoring smaller patients that we are monitoring them very closely, as we can't see if we're having to bag our patients. We don't have a meter here, so you have to just be very careful. That's it. I am going to place a catheter in this patient he's getting neutered today. This big guy is also getting a canine extraction. So Dixie is restraining. He has been pre-medicated with some ACE. Going to shave his leg to expose the vein. Hey, buddy. So now we alternate. We want to do a scrub, and we'll alternate Chlorhex and alcohol. Big dog, so I chose an 18 gauge catheter.
Okay. Good boy. We're going to isolate the vessel. Easy, Jax. There we go. So I can visualize that vessel. I'm going to start a little low. I want to see a flash, which I have, and I'm going to advance my catheter. Don't move. Take a piece of dry gauze and clean that up a little bit. And I want to tape it in. Better with his pre-med.
Wayne, John.
That first piece is to secure the catheter. Now we're just a little extra reinforcement. I put my final piece of tape, I'm going to flush it to make sure that it is patent, and I'll do that by pulsing my flush, and I can feel it up here, so it is good. So I have a piece of vet wrap just for a final. There we go. Now we're going to secure the T-port. Go around like this, yeah. That's a little bit short. I have an extra piece. There we go. And he's all set. Thanks. Harrison's getting a B12 shot that goes subcutaneously today. So we want to tint his skin and go down into the fat. Pull back, there's no blood, and then push. That's it. Okay, I'm giving this patient an IV pre-med. He's getting neutered. He's a little bit crazy, so we're going to give him some ACE. And Dixie, our strainers, holding off. I'm going to tell her to let up. And that's it. You can stop. So I'm getting ready to intubate him. The way I chose this size is that I just measured this compared to his nose, and I'm going to estimate about how far I need to go in this way. This is really long, so I'm not going to be going very far, about to there. And then I'm going to check that it holds its inflation, which it does. He's already been pre-medicated, so he's feeling pretty sleepy. I'm going to get rolling here. I'm going to flush his catheter, make sure that it's patent. Feels good. I'm going to note the time, 9:58. Propofol is 2 induction, so 2 as needed, I mean. So as sleepy as he is already, I don't imagine he'll be getting this full dose. I'm just gonna stop there and see if we can, how we can go. A little flush. Looks like he is ready. You good? Alright, so I'm going to visualize the back of his throat. I'm going to lift up his palate, push down his epiglottis, visualize his vocal folds, and go right down in the middle. This is a tight fit. I'm not going to be inflating this too much. I'm going to go ahead and get him hooked up to oxygen. And we'll put him on, just on 2. There we go. And I can tie this in. Ties are a little bit short, so I'm just going to tie it on top of his nose right here. So I can ensure that my tube is in place and give it a little pull and it's not moving.
Don't. Should see the bag moving. I see a flutter here, and I see a little expiration there, and we're doing all right. Okay. We want to make sure that we put eye lube in our patient's eyes to prevent any kind of drying out. So once I got him situated, slid back a little bit, put some generous amounts of eye lube in there. Okay, thanks. All right, going. All right, I'm gonna prep this patient for a neuter. The doctor's actually gonna do a total scrotal ablation, so I'm going to cut a nice square, clip a nice square all the way around here.
So his oxygen stat actually went down, but it was still high.
That's okay. Good to hear. You can actually, I don't know. Yeah, go ahead and turn it off. All right. So it's important while I'm shaving to keep the clippers flat against the skin to avoid clipper burns. And this is the terrain here is very different, and we're shaving a very delicate area. And I want to be very careful not to do any clipper burn or any cut. And then I also want to make sure that just for aesthetics, and I mean, it means a lot to our clients, our parents, that the shave job looks clean. So we want to make sure that we keep clean lines, a nice square over here. Okay. All right, so I just completed my clip. I had the doctor take a look at it to make sure that all my margins are done and that he's happy with my shave job, which he was. And so now I'm going to use our vacuum here to get rid of all of the extra hair. I'm going to clean up the table and really vacuum them up real well, and then I'll reconvene when I start to scrub. Alright, so I finished my clip, and I vacuumed, cleaned up all the hair, and I now have a stack of alcohol and chlorhexidine, and he's going to do a neuter, and then he's going to ablate the scrotal sac. So I'm going to scrub around in a circular motion like a target, being careful not to go over the same area twice and not to get into the hair. And I'm going to alternate alcohol and chlorhexidine every time. You can pause it, you can talk, whatever. I've just completed my pre-surgical scrub, so now we're going to do our best to not contaminate this area, and we're going to move him into surgery. Then I will be taking off all of this and going to do my scrub and stuff. Alright, so my patient has presented. It's crashed. The first thing that I'm going to do is yell that I need a doctor's stat, and I need nurses, I need help. And I'm going to listen for a heartbeat. I don't hear a heartbeat. Immediately start compressions. I'm going to yell for help again. I need some help. And I'm going to reach over here in my crash cart and grab the ambu bag and rustle around, staying alive, and get in the tracheal tube. I've stopped compressions. He's not breathing. So I'm going to check his airway, see if there's any kind of obstruction in there. Which in this particular patient, he's got a little bit of cotton obstruction. So I'm going to go ahead and intubate, get the ambu bag attached. We want to do about 1 breath every 10 seconds. So again, starting compressions again. This patient's less than 15 pounds, so I'm just going to use my 2 hands. I have my thumb right over his heart, and I want to squeeze my hands together. Staying alive, staying alive. Hopefully by now more help has come, and they have put in the catheter. Now I have compressions, which is my C, airway A, breath, C, A, B, and then drugs with our venous access, and then E is our EKG, so we'll start hooking up our monitoring device. And then we just follow our doctor's orders at that point, and that is a CPR. I'm going to transport this patient into surgery, so we just emptied out gave him a big breath, and we disconnected him. So now we're going to unlock the table. This part's going to move pretty fast. I'm going to spin him around and go butt first.
What are you doing, Amber?
I'm tying in the patient now. Gonna get him situated since he's a big guy. He'll definitely roll around. This one's a little bit difficult because it's hooked up to the Doppler. Ashley's about to place the esophageal stethoscope, which will give us a heart rate on our monitoring device over here. There we go. Still paying attention to his heart rate as we're listening to the Doppler, being aware of that, and also paying attention to his respirations since we've moved him and changed his position. Man, what a tricky time with this leg tying in here. Got my side tied in. I'm gonna hook in whatever monitoring Ashley hasn't finished up here.
There's probably a bigger cuff in the drawer. That could work. There's probably a bigger one. 2 more down, I think. Green.
Go ahead and get our first blood pressure reading. Blood pressure. What else have we got here? We lose our Doppler when the blood pressure is reading, so we might need to feel his pulses if the esophageal stethoscope hasn't started reading yet. You can also feel for lingual pulse. Here a little bit. Good strong pulse still going. We need our SP3 monitor hooked up, which will also give us a pulse and will tell us our oxygenation, saturation. We want to hook that up to anything pink. And this is our esophageal stethoscope. So we got blood pressure. We've already got our end-tidal CO2 hooked up too. So he's hooked up. Our pressure is 105/55, which is good for starting. Pulses are at 60. SpO2 is at 94. We'd like that to be just a little bit higher, so I can try adjusting that a little bit.
I'm just gonna.
I'm monitoring anesthesia for this patient. He's having some toes amputated, which could be a painful procedure. I want to pay attention to his heart rate and his blood pressure. And we do have some pain medication on board to help with that. Currently we have a video of us hooking him up, and we've got our blood pressure is measured right here. And this is our end-tidal CO2. I want to make sure that that stays below 60, below 50. If it gets any higher, then I'll just want to take a breath for him and breathe for him manually, get some more oxygen in his blood to decrease the CO2. And SpO2, that measures his oxygen saturation. That's actually a little lower than what I would like it to be. Anything below 95 is cause for concern. Anything below 85, he's going to want to alert the doctor. So at 92, I can probably just adjust it on his tongue and try to get a better reading, maybe on the other side. You can also use his ear.
give that a minute to reread. The heart rate here, which is on 84, 81. This is okay to gauge, but pay attention to the most reliable thing to listen to is his Doppler down there. I count that pretty much all the time, but I record it every 15 minutes. I can also feel a lingual pulse on his tongue as well. His temperature is measured over here as well, 96.5. That's much lower than what I would like. We do have him a bear hugger on to try and regulate his temperature. Hold on, we need to fix that. So when the doctor uses his cautery, it interferes with the Doppler. That would be a situation where I would be listening to this or feeling for a lingual pulse. I did adjust the SP3 probe to the other side of his tongue, and it got me to 94, 95, which is a little bit better. I'm not so worried about it. I'm just going to watch it now. His pulse is at 79 to 80. It's okay. So if it gets any lower than that, I might want to adjust his isoflurane. Right now he's running on 0.75, which is great because he's got fentanyl on board, which is helping with keeping that low. We'll go ahead and get a new blood pressure, see how we're looking. 11:15, so I'll record some vitals. I'm going to check his mucous membranes are nice and pink. Position of his eyes, our ventral medial. I like to, every 15 minutes, like I said, I like to manually try and see his respirations myself. So I'll just carefully, not to interrupt the surgical field, the sterile field, look underneath here and see his chest moving if I can't see it up top as well. But I can actually see him moving up top. Blood pressure is 111 over 63. That's a really great blood pressure. I'm really happy with that. SpO2 96, that's really great. He's pink. Respirations are reading at 10, which is great. End-tidal CO2 is 48, that's really great as well. It's in range. Temperature, like I said, is 96.9. We've got heating elements on them. And what else? Isoflurane rate is 0.75. Oxygen is running on 1. Heart rate's dropping down to 70. That's a little low for what I like, so I might turn him down just a little bit more to 0.5. I'm going to check his pulse myself. Since I can't hear the Doppler. Got 23, 72, that's about right. So with the exception of his temperature, I'm really happy with the plain anesthesia that we have our patient in right now. Sorry? Okay, I'm about to do my sterile scrub to go into the sterile surgery room. I've got my coat here, scrub, and forehead canine. Get it all mixed up in there. The important thing to remember is that I keep my hands above my waist and my elbows. There's a nail clipping
I'll continue doing this until 10 minutes is up. 5 minutes is up. Then letting the soap and the water drip off my elbows.
You're very welcome.
I'm assuming Dr. A is going for mobiles.
Yes, that's correct. Sorry about the interruption. Place still working right now? Get down low so as not to bump the faucet. Hands up so that the water's dripping on my elbows. I'm still good on time? I made sure to take off all my jewelry before I started my scrubs. You just notice that I'm not wearing my watch, which I would typically always be wearing. Any kind of rings that you might wear need to come off as well. I did that already.
Yes, yes. Yes, let's go ahead and do everything.
Okay. Just gonna finish up this one hand.
Can we keep going?
Yeah.
Thank you. But yeah, he can get all the normal treatments now. Sounds like she's gonna give him.
I did already open up my gloves and my gown in the room. So as not to have to wait for anyone.
Oh, you did?
Bring
Okay,
my
perfect.
extra
Okay.
blood
Well, let's
in.
grab some AD, let's grab some other syringes.
I did syringes, I took those already.
Perfect.
Hey, Dr. Raymond. I'm gonna tell you, would she be okay to go outside or anything? Yeah, I don't mind being real clean that, but if you don't.
Guess maybe we could just do real quick outside.
Yeah.
Yeah, because he was pretty good about it earlier.
Keep my hands
so,
up
yeah,
still?
we could
Well,
just
I don't
real
know, he
quick
got
outside.
really,
Does he get too worked up
he did
afterwards?
last time.
Okay, well, let's skip this walk then and wait till
He
later.
really-
I have my towel and my gown. I'm not sure what to do in terms of. I'll use the other side.
We'll figure that out later.
Yeah, I already used mine.
I figure we know who to collect from. Exactly. Yep, okay. Right now. I got you. Okay. Water again.
This is going to be a closed gloving, so I'm going to keep my hands in my glove, my gown.
This one is layered or lard or?
Layered.
Layered. all sideways now. You can always slide it off and reposition just so long as I stay sterile. So I have it all twisted. There we go. And the name. Tricky. Anna, will you tie me in?
Yep.
Perfect timing. Want to keep my hands up between my waist and my armpits. Okay. And I'm going to stay like this. Yep. You pull off. There you go. Yep. And I'm in. You can turn it off.
Grab the corner. And just kind of give it a, yeah, and then just kind of shake it. Okay, now the light blue, we don't want up, we want the light blue down.
Okay.
Okay? Because the light blue is actually pretty self.
Okay. So can I just,
You have to, yeah, you flip it around.
I mean, it's all sterile, so I can just do this, right?
Yeah, it's perfect. So, and then hold the top down. Yep. And now you can apply. Perfect. Yep. Hold. Yep, that's it.
We don't want the blue filling up. Okay, go ahead.
So we started filming breaks all day, like setting up the room,
Okay.
putting everything together. And at 4 o'clock, we were waiting till at the end of the day to surface. And sure enough, like 5:05, they said, hey, you've got one thing to do. And I was like, not the one thing at that point, if she's on a plane last night to go to Colorado. So it's like, well, let's do it today.
Oh, I should have straightened that up first.
Can I help?
Yeah.
So, there we go. Okay. Corner. Yep. Looks good. No.
Remember, ring, finger. Both angle into the skin.
Your angle is too shallow. There we go. Yep. There we go. And then trick, like up. You got it. Trick. Go like that. Hold it. Yep. Moving steep. Moving steep. Good.
Reach or walk around?
I would reach. Like I don't have time, so I just. Let me watch your out. Be in front of your drape. You can touch your drape.
Oh, I see. Okay.
Perfect. Yep.
Like
Good.
this. And we have to do that all. For heaven's sakes. Yeah. Has just this hand. I do it this way.
Mm-hmm.
Well, that's a good bite too.
That's
And
okay.
it's
I'll compensate. It's okay.
Tell me when you're done.
you can stop now.
Completely set up.
Okay.
It's awesome.
You need to count the drapes, the squares.
Yeah, which the most.
Are they rotating or?
Yeah, it's a must. Like I have to make sure that everybody can do everything, so that there's not a gap. And I think it's working pretty well. Rob, count it up a little bit.
Yeah, 20.
I'd say the most difficult, thing that we drape in is probably, a limb. But it goes pretty well actually. The room is pretty small. I'm hoping that.
Yeah, I'm not getting very good picture on this.
Yeah, but when they redo the construction, I think they'll see by November it's gonna be done, I think. So the goal would be to give me 2 more feet this way and 3 feet that way.
You can show your patient. I want to take a minute and discuss the duties of a sterile technician. I'm just reviewing my video and I realized that I'm not really happy with my discussion there. So I actually rarely go into surgery at my practice. I work in radiology, so I apologize. I'm making excuses, but it was an overwhelming and exhilarating experience, but I did not describe what duties I was actually doing in there. And my number one concern is to be there for the doctor. It happened to be in that situation that we were doing an RNA, a resection and anastomosis, and so my job was to actually, I was holding the intestines while he was ligating and putting it back together. And so it was really important that I stayed very still and stayed and communicated with my doctor in case I needed to move, because I just could not drop my, I couldn't drop the lumen and contaminate the field. And so leading up to that point, it was very necessary for me to make sure that on the table there was 2 separate sections for our dirty instruments and our clean instruments, because we did re-glove and we did use new instruments, and so it was very important to keep the table as clean and organized as possible. I was also making sure that the tissues stayed moist and suctioned as necessary. I'd never suctioned before. And passing instruments, I did that in the beginning, but towards the end there wasn't many instruments that I needed to pass. And being that go-between between the doctor and the circulating nurse, there was a couple of times where it was necessary for me to take something from the circulating nurse to give to the doctor. And so it's really imperative that I stayed sterile, and the way that I do that is by just being aware. I keep my hands up, and in the sterile field I was aware of my body. I really didn't move at all, but any kind of draping malfunction or dropping of my lumen would have broke sterility, or even taken things from the circulating nurse. I could have broke sterility then had I slipped or had she slipped as well. So that was my responsibilities as the scrubbing nurse. I just finished surgery on our patient here, Penelope. She had an RNA, and I was the scrubbing nurse. We're waiting. She's running on just oxygen now, waiting on her to wake up a little bit more. After we get her into a recovery cage, I'm going to clean up in here, which entails making sure that I know where I have all the sharps. I'm being very conscientious of the sharps. I have a scalpel there, and we've also got random needles laying around that I'm just going to throw into a steel bucket here that we used previously for saline. We also want to make sure that we keep count of all of the different sutures that we use for charges, and then we also have a sample which I've got packaged over there in a formalin. It's in a 10-to-1 ratio, and I'm going to package that up and send it out to the lab. Okay. So after surgery, we place all of our instruments into a cold water bath here that is sink filled up with some cold water soaking in Septazyme, which is an enzymatic instrument pre-soak. This will soak in the cold water bath for about 10 to 15 minutes. After that time, we will drain the sink, turn on some cold water, and with a stiff metal brush, scrub the instrument all over. You want to get all the organic debris out of all the little nooks and crannies, making sure to get the tines and the handles and kind of around these rubber indicators. Once you rinse it off and get the scrub down, we'll drop it into the ultrasonic cleaner where it will agitate for about 15 minutes. We'll cut. And then after 15 minutes, we can take it out. Alright, so the ultrasonic cleaner has finished its cycle, gyrating for 15 minutes. And I'm now going to remove all the instruments and rinse them out with cool to warm water and lay it out on a clean blue towel. This is pretty cool. I'm not going to videotape the whole procedure, but once I've taken everything out of there, then I'm going to get the milk. I'm going to spray it on one side and then flip them over, making sure that they are open. All the hinges are open. And spray that side. And then they'll sit until they dry, and then we'll pack them into their packs or their envelopes. Okay, so I'm going to wrap a minor laceration pack. I've started out with 2 cloth drapes here, 2 cloth wraps, and then I have a towel, a hand towel down in the middle, and I've got my steel bucket on top, and then I have 1 more cloth that'll go down on the inside of that. So we know we need a brown accent forceps and a blade handle. We'll put those in there, and then I've got my stacks of instruments here. I will need, our doctor likes to have 4 clamps, 3 pairs of scissors, sharps, blunts, and a pair of curved Metsin bombs here. Metsin bombs. Alright, let's get this on right. There we go. And then we'll put our those are blunts, and these are sharp blunts. And we also have our needle driver there, and another type of crushing clamp there. And so we'll go ahead and hook that together, place that in our bucket. Minor laceration packs only get 10 sponges, so you want to make sure that you count these. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. It's important to know how many sponges are going in because we'll count them before we start and after we end as well. We have 4 drapes that go in there. I'm going to pack this pretty tight. And then on top we place napkin with our 4 towel clamps here, drape clamps. this is the first thing that we'll use. We'll first use our clamps to clamp our drapes. And we'll fold this in real tight. Do the same again. Oh, I forgot something. It's important that we have our indicator strip, our steam indicator strip, that has not been, you can tell that it's not been exposed because it says that the K and the arrow will all be black, which it's not. So we will tuck that down into our pack so that when it's unwrapped and ready for surgery, the doctor can tell that it has in fact been sterilized, that's reached all the way on the inside. So now we'll just wrap all this back up. If I had gone ahead and wrapped up the whole pack and realized that I forgot it, then I would need to unwrap the entire pack and put that indicator strip in there, because without it, then the pack isn't trustworthy. Now, we want to keep it tight and leave flaps. So we'll fold it up real tight. And then fold this back. And do the same, real tight. Fold this back. Try to keep your fold straight. Creases straight, I mean. Fold that back. And these are the tabs that you'll be using to open up the pack and maintain sterility. And fold it in a little bit. Fold that in a little bit. And grab that whole tail and pull it up real tight. And then we're going to tuck it into the two previously folded flaps there. And now we'll just do our second layer. Push it down flat. So now we'll put a new piece of sterilization tape on there. I actually like to fold a little tab on mine so that when you're going to open it, you can grab it and it'll hopefully pull your tab with you. Now on here we'll want to wrap I'll put my name, what the pack is, that it's a minor laceration pack, and I'll also put today's date on it, that it was wrapped today. And that's a completely wrapped sterile pack. Thanks. So I'm going to demonstrate how to fold a surgical gown. This is actually a cloth gown, but it's the same principle. This is a paper gown, but it's the same principle as a cloth gown. The first thing, first way I start is to put it on the table like you're going to wear it. So this is actually would be the outside of your gown, which would need to remain sterile. And we fold it in on top of that. So creasing the top, creasing the back, lay your arms in. Do the same on the other side. So both of your arms are folded in. And we're going to fold these flaps back. Even put everything in a straight line. So all these little ties are going to go back. Straighten up the armhole because when the surgeon unfolds this, the armholes need to be right there so we can slip his arms in there. And we're going to get on this side as well. Now that everything's folded nicely, tucked in, I'm going to fold this in half, flatten it out. This out. You can put your feet too. Now fold this back. We want to do an accordion, so we're just going to accordion all the way up. And this is so when the surgeon or the nurse, whoever is putting on the sterile gown, when they pick it up, it'll just unfold all together without getting caught. So the surgeon or the nurse will just be able to pick it up right here, hold it up, and put their arms into it. You can stop there. Okay, so I have my accordion folded hand towel to dry the sterile surgeon or technician's hands, and then my accordion folded surgical gown, and I also have my steam indicator strip, which is going to indicate that the steam has penetrated all the way through. They're showing that this is going to be sterile once you open the pack. Now we're going to fold this up. You want to keep it tight, and we're going to double fold it because that increases the time, the shelf life of the sterilization.
Tiny little bit, that's what it is.
I'm going to fold over and then back. If it gets real long like that, we can always do a little double fold there. And now we're going to kind of tuck this in a little bit to make us fold it up. Keeping it real tight, pull it back. Tuck this into that flap, into both of the original flaps, leaving ourselves a little tail to open it up. And then we'll do the double. So this is surgical gown wrapped, and then the final thing that we do is take our indicator tape and tape it closed. Now this tape will actually, these lines on here will change colors once the tape has been exposed to the autoclave. I like to actually tape this to my tag sticking out, that way when you, it just kind of helps opening the whole thing up. So it's all taped closed, and then you can grab this tab and just rip it open. But on here we're going to write my name, what it is, it's a surgery gown, and towel, and then today's date. Okay, and that's it. Alright, so I'm going to talk about the autoclave right here. This is our autoclave. And we do maintenance on it about every 6 to 8 weeks, and the first thing that we'll do is to empty it using the pipe down here. This is also storage where we keep all the distilled water, which is what you want to run a sterilizing cycle with, is distilled water. But when we're cleaning it, we'll just empty the water out through this tube and then fill this up, this reservoir, wipe it out if you see any dirty in there, and then fill it up with regular tap water or distilled water, actually distilled water. You can just follow the directions. They're on the bottom of on the back of the bottle. It says 1 ounce of speed clean with distilled water. And then we'll run a cycle. Now, when we open it up, you can take this out and use a Brillo pad or any kind of stiff bristle brush to scrub all around it and get down below here. A lot of pulling and dirtiness gets in there, and you can clean this piece right here also. It gets a little bit dirty. So we do that every 6 to 8 weeks. Now when we're running a cycle, after the cleaning cycle is all done, we're back in action here. The important thing is to keep everything off the sides and the top. And this is a great design because it has a chamber for you to actually put your pieces in. So just place it in there, and then with these big packs like this, you just want to put them on the side, or if you do lay them down, we like to keep the paper up just because so the paper doesn't get too moist. But you want to make sure you push it down, nothing's touching the sides, nothing's touching the top. Close the door. Check your reservoir, make sure it's full of water, which it is. And then we run our autoclave for 20 minutes at 260 degrees. And you can stop it. I'm distracted. Right, okay, so now I'm going to run my autoclave load. Like I was saying, we run our autoclave for 20 minutes at 260 degrees. And I'm going to go ahead and start filling this up. And I did verify that there is water in the chamber, so now we're going to wait until this water fills up and covers the plate right here. Once it covers this plate, then we'll turn it on to sterilize, but this takes a few minutes, so I'll meet you back there. Okay, so the plate has just covered up. I'm going to go ahead and turn it to, I'm going to close my door, turn it to sterilize. And now it's going to go, we're going to run it for 20 minutes. The temperature is going to get to 260 degrees, and the pressure is going to get up to between 20 and 30 psi's, at which time it'll be sterilizing to the inside of our pack, killing any kind of bacteria that might be in there. This is a pack that just came out of the autoclave. It didn't just come out, but it has been already sterilized, and the way that I know that is that our autoclave tape here has the black marks. Before, if it had not been sterilized and exposed to the high temperature and pressure, then these black marks wouldn't be there. It would just look like a plain piece of tape. And to ensure that the inside of our pack has been sterilized, that the autoclave actually reached all the way to the inside, we have indicator strips in every pack that will turn brown. that's tucked all the way on the inside so that we can ensure that this pack is, this is actually a different kind. All right. When steam processed, K and Arrow match black, which it does. So this pack is sterile. And you can turn it off now. I'm going to discuss the different types of suture needles that are available to veterinary surgeons. I have a stack of suture that I took from work, but it turns out that all that I have is reverse cutting and taper here. So I went online and I found this really great resource which has all the different types of needles that are available with the cutting that's on there. But really there's only 4 that are really applicable that I was familiar with, that I felt like I had seen in my reading, and that was the blunt, the taper, the reverse cutting, and the conventional cutting. Now I've actually seen the most the reverse cutting and the taper needle. I know that we use the taper needle very often to use for skin. It's got a very sharp point, and it spreads the skin apart as it's going through, so it's less traumatic for the skin and it'll heal a lot easier. And then the reverse cutting, I know you want to be careful when you're using that because the cutting edge is actually on the convex side of the needle, and so you wouldn't use that when you were going up on the lower level of a closure on your abdominal layer, perhaps, because you don't want to be closing over something that you want to cut, like an organ. So that would typically be used on the outside layer of your skin closure. Same with a cutting needle. You would be using that for skin, and also for your sternum. We had this really cool surgery with a cat whose sternum was turned in, and we pulled it out, and he used a cutting needle with that. And then the blunt needle, we would be using those needles when we're using very tender tissues, like your cervix, not your cervix, I'm sorry, but a patient's cervix or the spleen or a liver, if for whatever reason he was needing to ligate any portion of that. The 2 that I have here are actually a reverse cutting needle. It's kind of blurry. And then we also have the taper needle here, which I was describing with the sharp point that spreads out. And you also wanted to know the size, shape, and uses. The shapes of the needles, they almost always are, that we used here, are swaged needles, meaning that the thread, the needle comes with the thread on it already. We're not eyeing any needles, threading any needles. Typically those types of sutures are a lot more traumatic because the eye of the needle is just a little bit bigger, and so it causes a larger hole that needs to heal. And there's also a straight needle, which I haven't seen, but I've read about. I've also read that that's great it's applicable use for skin closure whenever you're not going to need to use an instrument, that you can just use your hands, and also for purse strings, because the curved needle could potentially snag the anal gland, which you wanted to avoid. You're just trying to do a little purse string around. So a straight needle would be great for that. I did also read about needles that have points on both ends, and those are typically used in large animals. That's it. I'm going to talk about different suture patterns now, and I especially think that it's important that we know this as nurses, because we are typically doing suture removals, and it's important to know how the suture is actually placed into the skin for us to know what to expect on how to pull it out. I printed off a couple of pictures off the website that I liked, and one I actually can't say I like at all. I think it's pretty horrific, but it's very accurate, and it's an example of a purse string. We may or may not be placing these or taking them out, but it's still important to understand how they're put in there. A lot of times we are aware of them for reminding the doctor to take them out. But this would be an example of what we would do on an anus if we were doing any kind of surgery that was around there and we needed to make around the dog's back end, like a mass removal. We need to make sure that the area stayed sterile. Maybe if we were doing a feline neuter, also we would use a purse string. This right here would be an example of a simple continuous. A lot of times that is the easiest and the quickest. The bad thing about a simple continuous is if one of these were to snip or fail, or if one knot fails, then the whole closure will fail. And so that's one of the downfalls of the simple continuous. My experience with a simple continuous is when we did the necropsy, the doctor had me just close the patient after the procedure was done and suggested a simple continuous, and also our surgeon used a simple continuous when closing the subcutaneous layer of an abdominal surgery, and I actually learned how to run the suture, keeping the thread tight while he ran his sutures. There's two examples here of different mattresses, and I think these are applicable and really important when we're definitely concerned, which we're always concerned about, the actual aesthetic look of how the wound is going to heal. That we want, just a very minimal scarring, and we want the edges to be opposed very nicely. So a lot of times these mattresses will be used. As far as ease of removal goes, I think they're all pretty similar. The ease of putting them in there may be different. You'll go through a lot more. One of the disadvantages is that you'll go through a lot more suture, being that each individual, it's one knot, and you tie, and then you go to the next tie. So you use a lot of suture in that, whereas with a simple continuous, you're not going to use a lot of suture. You're just going to run it and be done. And then the final here would be a cross mattress, and a lot of times I've seen this used for laceration repairs, and when we're doing suture removals, these are very straightforward. You just get it in clip, and one little tie is going to come out. So this is a closing an abdomen as well. This might be appropriate for that. It would be time consuming, so probably not for a large animal, but it's another option as well. And the types and uses of common suture patterns was 9.3, and I think I covered it. I'm going to talk about the different sizes and types and uses of different sutures now. I have a stack that I just borrowed from work, and so I'm just going to go through and talk about them. The first thing that I think is the easiest to talk about is their size and the way that we are asked for them as nurses. Most of the time we're just asked for as 2-aught, and that refers to the aught, refers to the number of zeros, which refers to the actual fineness or denseness of the strength of the thread. And so of the stack that I have here, 1 is going to be the thickest that I have. There was a little discrepancy in our books, or a little difference. The big veterinary textbook said that 7 would be the highest, whereas the surgery anesthesia nursing book said that 5 was the largest. But either way, 11-aught was the finest, was the smallest. So going down and getting finer, 1 would be a rope, and then we would be going to like a hair, for instance. So 1 is the thickest that I have, and then 0 or aught would be my next, and then I would do 4 would be finer than that, 3 would be even finer than 4, 2, and that's all I have, because my other 2 are 4 and 0. So going from thicker to thin would be 1, and then the number of zeros is finer and finer and finer, and the 2-aught means that there's 2 zeros. Now, if that wasn't confusing, they're non-absorbable and absorbable. There are 2 non-absorbables that I have here, and that would be my silk and my kermit gut. Gut is for any kind of soft tissue surgery, any ligating. Doesn't seem to be the veterinarian's preference of late. It is made of natural animal material, which has a high reactivity among patients. So we typically don't see that used very often. And then silk is also natural. It's a braided suture, meaning that it's not a monofilament. There's a multifilament. I'll go over that in just a minute. But silk would be more of a fine, easier to use for delicate, sensitive tissues like maybe a lip or an eyelid. And then my absorbables, I have PDS is a good absorbable suture option. That's probably the one that I'm most commonly hearing in surgery. Our doctor uses these for skin sutures. He uses them for ligating. And a 4i is pretty fine. That's relatively fine. And I have another PDS here, a 1, which, as we know, is now thicker. So perhaps this 1 would be used for closing that Great Dane after his GDV surgery. This would be used for that outside final closing. I also have a Vicryl here, which is an absorbable, and that would be a great option for any kind of dental procedure. If we have a tooth extraction, a lot of times that carnasial tooth that comes out, that needs a flap and a suture, and so this would be a great option for that. And I also have one thing that I don't have here, which is a great example of a non-absorbable natural suture, would be the stainless steel, the staples. There's also, stainless steel suture, but that's very difficult to work with and can tear the gloves and can kink. So a lot of times you just see the staple being used, but it's easy to use. It's got to be removed. It's non-absorbable, but it is a natural option.
Okay, so we're getting ready to do a suture removal on our kitty here who had a laceration repair. Her sutures have been in for 2 weeks, and you can tell that the wound has definitely healed. It's got nice scarring, even some hairs started to grow back. We would know that they weren't ready to come out if there was any dehiscence, meaning that the wound wasn't healed completely, or there was, all right, baby. There might be some bleeding, some pussy discharge.
Sorry, we're gonna have to go with the death grip.
Oh dear.
Okay.
All right. So we're just gonna snip these out real quick.
Hey, Sabrina.
Easy,
Sabrina.
baby.
Oh, in your little snip.
And snip. And
I know, sweetie.
so we're almost there, baby.
Sorry, don't get scratched. I know. I didn't snip it all the way. They're a little dull. Hey.
We're almost done, Katie. There we go.
I know. Oh. Sorry, it's loud on your video. Wow,
There we
that
go.
is.
Here we are.
Okay, that's it.